Thanks for joining us this morning. So tell me what's going on that's exciting at Genentech right now. What gets you motivated to go to work every day?
Well, it's a very, very exciting time right now in terms of science. I think you've probably heard a little bit of that today, but things like gene therapy, cell-based therapy, potential for curing devastating diseases. That's very, very exciting. From a Genentech standpoint, for the last 20 years, we've been pretty much synonymous with oncology. And we're very proud of the progress we've made or helped make in the field of oncology. Right now, we're building on our experience in oncology and moving into neuroscience in a very big way. I think people will know that we've had drugs for stroke. Just a few years ago, we launched a very, very important medicine for multiple sclerosis. But when we look at our near-term pipeline, there's just some really exciting drugs for neuroscience. These drugs have the potential to deal with devastating things like neurodegenerative diseases that rob us of who we are. And the science is very, very exciting. And we have 14 drugs in development for neuroscience. And just a few examples. We've got the first oral drug for spinal muscular atrophy. We're just in the filing process for that. We've got the first disease-modifying treatment for Huntington's disease. And then we've got the only drug in phase 3 development for autism spectrum disorder, which I think everybody understands is a very, very difficult disease which impacts a lot of people and, more importantly, their families and their communities.
So these are drugs that clearly have high unmet need, often taken by people who are very sick and in a very bad situation. What stops you from setting just an exorbitant price that these people could never afford?
Yeah, so we take pricing as a very, very serious topic. The last 9 drugs that we've launched, we've launched them at or below the current standard of care price, even though in most of those situations with the regulatory process, we've proven we're better than the standard of care. So for example, I mentioned the drug in multiple sclerosis. We actually priced that at 25% less than the drug that we showed that we beat conclusively in the clinical studies. So pricing responsibility is something we take very, 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 very seriously. Now, we've got a very complex healthcare system in the US. There are cracks. So at the same time, we also have comprehensive support programs like the Genentech Patient Foundation that provides free drug for about 60,000 patients a year. So these are for patients that can't afford the medicines. They don't have insurance coverage, or their insurance carrier says they won't cover the drugs, or they're having difficulty affording the medicine.
Great. So earlier today, we talked about the legislative proposal that's moving forward into markup that would use international reference pricing for a specific set of drugs and Medicare. The CBO has said that would have an impact on the development of new drugs. Can you tell me, though, as a CEO, what decisions would you make differently about your investment in R&D or your commercialization if there were international price indexing in drugs in Medicare that didn't have a generic alternative?
Well, thanks for asking. And of course, that's the subject of today's session and why I'm here in Washington, because this is a very, very important time. We're an innovation pure play company. We don't have a biosimilar division or a generic division or a consumer division. We are an R&D company. We invest $11 billion a year in research and development. And the sorts of work we do, as I hope has come across through the remarks I've already made, is we go after the really, really tough challenges. And the concern is, and I think it's really a significant concern we should all be aware of, is that legislation like H.R. 3, we believe, will significantly impact innovation. The Congressional Budget Office, I think, conservatively estimates that there will be an impact of maybe 15 less new medications if H.R. 3 happens. I think that's conservative. I think it's going to be much, much higher. The reality is that what is going to happen is that the really tough diseases, where you're taking the really big scientific bets, that's the first ones where the research is going to lessen. I personally was involved in our decision to go big in Alzheimer's. We've spent $2 billion in Alzheimer's. We have this much to show for it. But we continue to have drugs in research and in development in Alzheimer's. And that's because we believe that there will be a marketplace at the end of it. So I think it's those sorts of drugs which will be the ones which will suffer the first. And I'm confident that, unfortunately, the decisions will be that you'll go for the smaller, easier scientific bets rather than the big, tough diseases that we know as a society we need to solve.
But you do negotiate the price of drugs with governments in other countries. So why wouldn't you just want to do it in the U.S.? Why wouldn't we just take on that same system here?
Well, I think you when you look at HR3, you see that it's actually, it's very, very clear. It's not really negotiation. And this is our experience of working across the world. So there is quite a few people here who are, I don't mean in this room necessarily, although it would be interesting to poll the group, are flirting with this idea of international reference pricing. But that presumes that those countries do it right. They're very, very different systems with different priorities, different economies. And those prices, we believe, aren't the right prices. The US drives the innovation in our industry. And the US, by and large, has it right. Now, that's not saying that there aren't changes that need to happen. And that's the other thing that I would really want to communicate is, we've got to make sure we safeguard innovation, but at the same time, absolutely, there is a problem with out-of-pocket costs for drug costs. There is a problem with drug costs in the US. And as a company, we want to solve those issues. We think the solution is market-based reform, where we can make the market work much more efficiently to increase the competitive incentives at play, rather than involving the government, because we think the government involvement will have a dramatic impact on innovation. So I'm not here saying, we don't need to do anything, innovation's at threat. There is absolutely things that we can do to reduce out-of-pocket costs for patients, which is a really critical issue.
So since you mentioned that, if you were writing the next piece of legislation that would reform the market, reform how drugs were reimbursed, what would you do? What would you do when you put pen to paper?
Well, I think, just building on the topic of let's make the US market work really much more effectively. Right now, the system doesn't fully allow competitive forces to work. So one of the ideas that we're proposing on Capitol Hill, and I've talked to lots of senators and House, I've been to the White House as well, is the concept of market pricing model, which is basically, let's increase the level of competition on the private insurance side in Part B and allow Medicare to take advantage of those increased discounts. Now, for those of you that are sort of deep in the policy area, what we need to do is change the ASP calculation so that physician practices aren't put underwater, and we can really allow companies to contract more aggressively with insurance providers. That's one thing that I would do right away. At the same time, I would address the Part B, Part D out-of-pocket costs of patients in terms of the benefit design. I think that's absolutely critical. So you could take the savings in the first one, and you've got to really address that. Anything that we do has to flow through to the patients. That's where the issue is. I would also, look at topics like combination drug pricing. We have another proposal there. That's where oncology is moving, is to more and more doublets and triplets. And at the moment, with the US system, unfortunately, that means it's 1 + 1 = 2. If we had unique codes for combinations, which we're proposing, we would be prepared to lower our prices for those combinations. And this is a precursor of what you heard in the prior panel. This allows us to move towards indication-based pricing, value-based pricing models, and I think really start to allow competition to happen. And in many European countries, we can do this, but unfortunately in the US system, where prices are set on a per milligram basis, this is not possible. And this is not where the science is. The science is moving faster than our payment systems.
Well, thank you very much. Thanks for sharing your thoughts with us this morning, and good luck bringing those innovations across the finish line to the patients who need them.
Thank you very much. Thank you.